Hi, everybody. I'm Shaddy Saba. I am a licensed clinical social worker and a doctoral candidate at the USC School of Social Work. I'm also a student leader at CASE. It's been wonderful being involved with CASE. And I'm going to be presenting on a study on advancing the science of pain among veterans, so moving from military to veterans, and it's a data-driven and biopsychosocial approach. And so pain is another problem that's really, really prevalent among service members and veterans. Over half of military veterans have pain, and it's even more prevalent among veterans with post-traumatic stress disorder. So, when you think about problems that among veterans, you probably think of PTSD. And so those with PTSD, even higher rates of pain. And what's one thing that's important to study and kind of understudied when it comes to pain generally are what are the things that influence dynamic changes in pain. Like, so we know that pain is not just a static experience. Things make pain go up, pain go down on a daily basis. But we don't know a lot about what those things are. And so important to kind of disentangle that or start to. It's challenging to get at that question. And health generally is challenging and complex to study for a lot of reasons. But one reason that I think about a lot is that health and pain specifically are biopsychosocial problems. It's a biopsychosocial problem, which means that pain is not just about, physical injury. It's not just about getting hit, being injured, tissue damage. It's also about, mental health symptoms, loneliness, race, ethnicity, sleep. These things we know are all associated with pain, are all important to think about when it comes to veterans. And so disentangling, the associations between just the litany of factors that might influence pain and how they actually influence pain and how they might interact and the directionality, it's really, really challenging. And our models in the social sciences, our techniques, our methods are not very good at disentangling that complexity. And so one of the reasons I became really excited about working at the intersection between social and data sciences is because, I'm learning that the models that you all are really, really good at are, I think, applicable for helping us to get at that complexity. And so with, the methods and techniques of computational and data sciences. And so the aim of this study was to identify the factors associated with increases in pain. So sort of, do I have more pain today than yesterday, specifically among veterans with post-traumatic stress disorder. The data source for this study was actually kind of a study that was incubated here at CASE. The Maverick study, PI is my primary advisor, Dr. Jordan Davis, also Pisa Dilkina is a investigator on that study as well. And so it's this study where veterans are reporting on their symptomology on a daily basis and also have wearable devices to, the purpose of that study is to predict escalations in PTSD. So for 88 days, we're collecting both of those kinds of data. And the participants include 74 veterans with post-traumatic stress disorder, and these are sort of their characteristics, skew pretty heavily male and white, which is typical for this population. So as I said, we have 88 days of data collection, and the outcome is starting on day 30, how many days until somebody experiences an increase in pain. And we're starting on day 30 because I'm utilizing the first 30 days and the baseline survey to kind of pull predictors, pull features, essentially, of that pain increase starting at day 30. And so the predictors include, when you think of that biopsychosocial model, considering the surveys that we're giving out, we pulled as many things as are sort of feasibly associated with pain, things at baseline, kind of fixed variables at baseline, and daily averages of a bunch of sort of mental health and social interaction, as well as right before day 30, so from 23 to 30, is there an increase in or decrease in some of those symptoms, so proximal increases. I should also say this analysis doesn't include that passive data, that Fitbit and wearable device data that's still being processed. And so, like I said, that the outcome is, days until an increase in pain, specifically in clinically significant increase, which is 2 or more on the numerical rating scale, and utilize 2 kind of complementary machine learning survival models. And survival model is, to model time until an event. So both random survival forests and regularized Cox regression. So this is time until a pain increase in the full sample. And the way to sort of interpret these survival graphs is basically as it goes to the right, the probability of not having a decrease goes down. And so as it goes to the right, the kind of the inverse of the probability of having an increase goes up, about 50% probability of having a pain increase of 2 or more points by the end. So looking at the results from the random survival forest, we can see kind of the rank order of some of the top predictors, post-traumatic cognitions, meaning like beliefs about your traumatic event, like are they kind of negative beliefs about self or the world, et cetera, positive affect, and then a few sort of social interaction variables, income, et cetera. And then from the regularized Cox regression, we get some magnitudes of effects, and so it looks like female sex is associated with relatively higher hazard of a pain increase, and then some overlap in the results there as well. Now we can look at kind of, taking let's say the top 2 predictors from the random forest. We can do these sort of prototypical plots where we split the sample by the top predictors. And so if you have high post-traumatic cognition, so again, those negative beliefs about the traumatic event, and you haven't had recent increases in the last week before modeling pain increases, no recent increases in positive affect, so no increase in joy or peace, et cetera, you had the highest hazard of a pain increase. And most of, it looks like it's like over 75% of the sample had a pain increase by the end. Versus if you did have high post-traumatic cognitions, but did have a recent increase in positive affect, you sort of look like everybody else. You look like the people that didn't have high post-traumatic cognitions at the end, which sort of, which implies perhaps or suggests perhaps that, positive affect may be protective, especially among people that experience kind of negative beliefs about their trauma, those post-traumatic cognitions. Now, the way that I modeled this was using those 74 individuals in a kind of a long format file. So it's a pretty small sample, and this should be replicated and tested with a kind of a test set in a larger sample. But this data set, we also have repeated measurements for each person, and so I'm kind of planning to move to a mixed model similar to what Eric and Aditi presented, where each individual will have sort of nested observations and kind of look at, does perhaps prior day lag influence subsequent day pain, also incorporating that path data when that comes in. So thanks a lot.